Hello. So we are here to do pharmacology. Pharmacology is supposed to be a complex subject, but we are going to go into it and we are trying to understand it and we are going to solve the complexities. What is pharmacology? Pharmacology is a science of drugs. The proper way of saying it is a science of medicine. And whenever you consume a drug inside your body, inside a human body, it's like two persons interacting, the drug and the body. Naturally, both of us are going to affect each other. Both of them are going to have some influence on each other. So, the drug starts affecting the body, producing effects on the body. As well, the body starts producing some effects on the drug. The first part of pharmacology, which is supposed to be a difficult matter, is called Pharmacokinetics. Kinetics. What's kinetics? Kinetics is movement. It means as soon as you start taking the drug inside your body, the drug moves inside the body. And you start doing the quantitative study of what happens to the drug. Its movement in, through and outside the body is studied under pharmacokinetics, and all this is what the body is doing to the drug. So you can sum it up as pharmacokinetics is what the body does to the drug. So what's going to happen to the drug? It's going to be absorbed, so absorption. It's going to be distributed throughout the body, so distribution. Then it's going to be transformed, so it's called biotransformation. Maybe metabolism, that's breakdown, or synthesis. And the basic purpose of the biotransformation is detoxification of the drug. And finally, the drug is going to be getting eliminated or excreted. So, as you see on this slide, the pharmacokinetics will include the time required for absorption, the amount of absorption, time required to begin the action, to start the action will be called onset of action, the duration of action, the bioavailability. Could you please pronounce it for me? Bioavailability. Fast. Bioavailability. Right. The half-life of the drug, the routes, dosages, and the frequency of administration. So that's all about pharmacokinetics, what the body is going to do to the drug. The next part includes a very beautiful word, and it's called pharmacodynamics. Whenever we say a person is dynamic, it means a person who's got great capacity to change the world. And this is why dynamics is about the effects that the drug is going to produce on the body. So you call it as what the drug does to the body. It's going to produce some pharmacological actions or effects. It's going to have a definite mechanism of action of doing it. So MOA is mechanism of action. Its interaction with the receptors, its adverse, unwanted or undesired effects, and finally its therapeutic application. So we already understood what's pharmacokinetics and dynamics. We need to know what is a drug. As this slide is telling you, it's a chemical substance used or intended to be used for diagnosis, prevention, cure or treatment of disease, the symptomatic relief, and the prevention of pregnancy, because pregnancy is not a disease. And this chemical substance, we are going to use it, or we have an intention of using it to modify the physiological functions inside the body or to explore the pathological states. Let's try to know what are the sources from which the drug is obtained. It can be obtained from plant source, and when it's obtained from plants, they are called alkaloids. Let's have a look at the names. Morphine, atropine, D-tubercularine, digoxin, papaverine, chloroquine, quinine, quinidine. Is it sounding like a poem? Yes. Morphine, atropine, D-tubercularine. Yes. Most of them, they end with INE. But the vice versa is not true. There may be drugs ending with INE and may not be alkaloids. So, the drugs obtained from plants are called alkaloids. And a common feature of all the alkaloids is, if you get poisoning by these drugs, you can use a substance called universal antidote to treat this poisoning. The second source is animal source, and most of the hormones like thyroid hormones, insulin, they are obtained from animal source. The third one is our earth, that's the mineral, and you can obtain iron, liquid paraffin, magnesium sulfate, and many other substances from the mineral source. Microorganism has been a great source for various drugs. For example, like Alexander Fleming and Fleury brought in penicillin, that's penicillin G in 1940s, and then number of antimicrobial agents like cephalosporins, aminoglycosides. When they are obtained from this particular source of microorganism, you start calling an antimicrobial agent as antibiotic because it's obtained from a microorganism, and mostly they are prepared from fungi or from actinomycetes. The next source is, of course, the scientific source, the chemical source, the laboratory source. So it's chemical substance derived in a laboratory, produced by efforts of our scientists. And there are hundreds of drugs. For example, ibuprofen, sulfonamides, trimethoprim, metronidazole, and all the newer synthetic antimicrobial agents are obtained from the synthetic source. The last source has been a novel and great source and is going to be a future source of many drugs, and that's called medical engineering or genetic engineering. It's called recombinant DNA technology. What is done is, we already know what's the code, what's the genetic sequence responsible for secretion of a substance, for formation of a substance. We already found the genetic sequence. We feed this genetic sequence to a microorganism and make the microorganism synthesize that particular substance for us. And Escherichia coli, E. coli, has been a great source for synthesis of new substances, what you call recombinant DNA technology. After sources of drugs, we are going to get to know how to administer the drugs, what are the routes of administration. And I'm trying to divide it into routes intended for systemic action and the routes intended for local action. Please don't call it local route or systemic route. Say route for systemic action, route for local action. Amongst the routes for systemic action, you have the common route of administration, that's oral route of administration. And because the drug is passing through the intestines, we call it enteral route of administration. And whenever you are using the gastrointestinal mucous membrane, you can have oral route, sublingual route of administration below the tongue, buccal route of administration, and the rectal route of administration. As far as the other route of administration for systemic action is concerned, it's parenteral route of administration, what people call parenteral. Let's start saying it, PAR-ENTERAL. PAR is beyond the intestine. So when your drug is not coming in contact with GIT, gastrointestinal tract, and is going directly to the systemic circulation, you start calling it PAR-ENTERAL route of administration, which may be cutaneous when you apply the drug to the skin and straightway gets into the systemic circulation, or inhalation when you inhale the drug and goes to the systemic circulation. The nasal mucous membrane sometimes can absorb the drugs and straightway take them to the systemic circulation. So nasal, and all the injections like intradermal, subcutaneous, intramuscular, and intravenous injections. Let's come to the oral route of administration. As we know, it's a safe route of administration. It's quite convenient. It's non-invasive and it's not going to give any pain to the patient. So it's painless, and it's very easily possible for the patient to have self-medication on day-to-day basis. And you don't have to make the formulation sterile because your gastrointestinal tract, gastric hydrochloric acid, is taking care of making it sterile. And obviously, this route is less expensive comparative to the intravenous and intramuscular routes. And there is no sudden hazardous effect expected because the drug takes some time to enter the systemic circulation. But all this is not good about oral route. There are some disadvantages too. And the disadvantages include, it's a slow onset. You don't get an immediate effect. So it's slow onset. Sometimes the drug may be non-palatable and the taste may be too bad and you would not like to take the drug. And you might get nausea, vomiting, gastrointestinal intolerance due to this route. And some drugs may be destroyed by gastric hydrochloric acid or by the liver during its first passage, what is called high first pass metabolism. Obviously, you won't be able to give those drugs who are getting too much destroyed in the gastrointestinal tract. Or for some drugs, the absorption may not be complete, may be complete or incomplete. If it's incomplete absorption, the drug may not be able to give you the expected blood levels. And if the patient is uncooperative, unconscious, and if the patient has too much of vomiting or swallowing problems, you cannot use the oral route of administration. Let's come to sublingual route of administration. What sublingual is like, you place a tablet below the tongue and the drug gets absorbed through the sublingual mucous membrane directly into the systemic circulation. Would it happen for all the drugs? No, obviously not. Few drugs can do it, and that's sublingual route of administration. One of the important advantages is, as soon as you have started taking the drug, it mixes the systemic circulation, and when you get to know the drug has produced the effect and no more effect is wanted, you can spit the tablet out and you can stop the action. You can terminate, you can control your own action by this sublingual route of administration. Let me give you an example. Nitroglycerin or glyceryl trinitrate used for acute angina, or isosorbide dinitrate, what people call sorbitrate, is a very common example for sublingual route. Buprenorphine can be used as an analgesic by sublingual route. Ergotamine tartrate for migraine, and hyoscine and methyl testosterone. Great advantages with sublingual route is rapid and instant onset of action. It's like injecting in a vein. You just put it below the tongue, and the drug gets absorbed directly to the systemic circulation. The effect starts. It's like injecting into the vein, instantaneous effect, and it's going to bypass the liver and gastrointestinal tract. No question of first pass metabolism. Almost 100% bioavailability, and you can speed the tablet and you can terminate the action if you need. Of course, this is useful in emergency. And on the other side, see, everything has bad and good incorporated into it. So obviously the disadvantages would be, it's got a short duration of action, it can't act for a long time, and it can produce a sudden hazardous effect. You cannot expect this route to keep on working for hours together. It will be only for emergency. So that's sublingual. Next we come to rectal. It's obviously an unpleasant, inconvenient and embarrassing route of administration, and the absorption is also quite slow, unpredictable and irregular. But still, this can come to our use occasionally. For example, if the drug is irritant or unpalatable, if you have to give the drug in large amounts, it may not be possible by other routes. You might need long and continuous action, and the patients who are constantly vomiting, you can try rectal route of administration, like you have suppositories for diclofenac, diazepam, and many other drugs. Please remember, it's not going to produce immediate effect, but it's going to produce a long effect. So that was all about enteral. Let's now come to PAR-ENTERAL. PAR-ENTERAL, beyond GIT. And you have cutaneous, inhalation, nasal, and the various injections. Cutaneous is also called transdermal route of administration. And as you know, if you have to cross a mucous membrane or skin of human body, the cell membrane is packed with lipids. Naturally, you have to be highly lipid soluble. If you can get dissolved into those lipids, membrane lipids, you can get inside easily. It's like behave like a Roman in Rome. If you are lipid soluble, you can get into it and you can cross. So those drugs which are highly lipid soluble, they get directly absorbed in systemic circulation to give slow and prolonged absorption and long and sustained action. You will bypass the liver. Nitroglycerin ointment can be applied to the chest wall and can get into systemic circulation, producing a long effect. Or fentanyl, a very popular analgesic, a narcotic analgesic, can produce a long effect by the transdermal route of administration. Next, very novel route of administration is inhalation for systemic effect. I'm not talking about the bronchial asthma inhalers which produce local effect. I'm speaking about inhalation for systemic effect. And the drug enters the systemic circulation. I'm talking about the general anesthetic drugs like the volatile liquids and gases like halothane, isoflurane, enflurane, etc. You can see this. This is isoflurane and this is halothane. This is inhalation for systemic effect. A rare route of administration is nasal for systemic effect. There's direct absorption through the nasal mucous membrane, dihydroergotamine for migraine, and oxytocin nasal spray for milk ejection. Then you have injections, intradermal, subcutaneous, intramuscular, and intravenous. Intradermal injection is injected within the skin, that's intradermal, the slow absorption, and this is mainly used for hypersensitivity testing in patients. Then next you have subcutaneous. Subcutaneous is below the skin and the absorption is slower than the intramuscular route of administration, and the drug gets absorbed over a long period of time, and you cannot inject too large volumes because you are going below the skin. Insulin injection is the common example for subcutaneous injection. Then you have intramuscular injection. Now you are getting some kind of a store like a muscle to inject, and the drug is going to stay in the muscle, and this drug in the muscle is going to serve as a depot or as a store, and this drug will then get into the systemic circulation. It is fast and better as compared to oral, but it's slower and giving less bioavailability as compared to intravenous. But definitely as compared to subcutaneous, you can inject larger volumes. You have to take care not to damage a nerve, because inside a muscle there is likely to be a nerve. And you need to take, of course, the precautions for having your preparation sterile. Lastly, we go to intravenous route of administration. When you give a single injection and is going to act for short duration and you give a large dose, it's called bolus. Bolus is a single injection. When you give a continuous intravenous infusion and you dilute the drug and inject it over a long period of time, it's called continuous intravenous infusion, and it's going to give a continued action, like you give insulin injection, continuous infusion in patients with diabetic coma, or when you give fluids in a patient who suffers from shock. What are the advantages of oral route? There's a rapid onset of action, straightway the drug reaches the blood. There is 100% bioavailability. You are bypassing the liver and gastrointestinal tract, so no question of the breakdown in between. There is no gastric irritation, and the unconscious, uncooperative patients who are in emergency can use this intravenous route of administration. Disadvantages are there may be a certain hazardous effect because straightway it's going to the blood. The patient cannot administer himself. Self-administration by intravenous is difficult. You have to take the sterile precautions. It means you need some expertise to inject. You have to spend little more cost as compared to other routes of administration, and you need supervision, especially when you are giving continuous intravenous infusion. Is it going to produce anything else? Yes. Depending on the nature of the drug, it might produce irritation, it might produce pain, it might produce inflammation of the veins, so what is called phlebitis. And if the drug extravasate comes out of the vein, it might sometimes produce irritation. So this was all about the routes for systemic administration. Now we go for routes for local action. When you apply the drug to the skin, wounds, burns in the form of ointments, creams, lotions, powders, you call it topical route of administration. You can also apply antibiotics like neomycin, gentamicin, etc. You can apply soothing agents like calamine lotion. You can apply corticosteroids like betamethasone. You can apply antifungal agents like nystatin and clotrimazole. And various mucous membranes can be used for this purpose. Is the oral cavity, pharynx, eye, ear, nose, urethra, anal canal, vagina and rectum. So many places you can apply the drug locally and it's going to produce local action at all these places. Please remember a very beautiful thing about oral route of administration for local effect. When you take a drug by oral route of administration, you obviously feel this drug is going to get into the systemic circulation and is going to produce a systemic effect. It's true if the drug is getting absorbed, but I'm giving you an example, oral route for local effect. So you have taken it orally and it's going to go through the GIT, so where is the effect going to be? Where is the local effect going to be? The local effect is going to be on the intestines. And I'm giving you an example of an aminoglycoside, that's neomycin, because aminoglycosides are very poorly absorbed when you put them into the GIT. So this neomycin is going to remain active, is not going to get absorbed, so no systemic effect, and it will pass through whole of the gastrointestinal tract and get out. While going, the drug is active because it's also not destroyed. So I'm using a very beautiful sentence. Aminoglycosides are neither destroyed nor absorbed by the gastrointestinal tract. And this is how this neomycin is going to kill the microorganisms in the gastrointestinal tract. And many times we use this in patients with hepatic encephalopathy to destroy the microorganisms, or we also use it sometimes to eradicate the microorganisms before operation or before surgery. In the same way, non-systemic antacids, whatever antacids we drink, are not absorbed and they produce just a local effect on the stomach. The next novel route is the route for local action in the form of inhalation. Some time ago we saw inhalation for systemic effect that were general anesthetic agents, and now what you see is this inhalation which the patients use for bronchial asthma. Inhalation for local effect is different, and this is going to produce only local effect on the bronchial smooth muscle, and it's not expected that this drug will be absorbed in significant amounts, and you're going to get local effect by inhalations. It will be interesting and beneficial for all your exams to know some newer drug delivery systems. And some of these drug delivery systems have already been covered in the routes of administration, but still I'll be highlighting and saying about them under the title newer drug delivery systems. Dermojets are the mass inoculations given for various vaccines. Then you have dermal implants or pellets, cyalastic or biodegradable implants like testosterone or levonorgestrel. You have transdermal therapeutic systems, TTS or patches of clonidine, nitroglycerin or nicotine. You have OccuCert, which is available as pilocarpine for glaucoma, and this is this transdermal therapeutic system. It's showing a clear backing film. Then there's a drug reservoir. The drug will be stored here. Then there's a membrane which is going to release the drug, and on the top there is a contact adhesive which is going to fit this particular patch on the skin, and through the drug reservoir the drug will be released below the skin. Is it going to produce a rapid effect? Obviously not. It has to cross the membrane of the skin. It's going to produce a slow effect, but it's going to give a sustained effect. So it's called transdermal therapeutic system. Then there are targeted drug delivery system in the form of monoclonal antibodies. You have liposomes which are incorporated with intravenous drugs like doxo and daunorubicin, gentamicin, and amphotericin B, a very important antifungal agent. You have computerized miniature syringe pumps for insulin and various hormones and for nitroglycerin. You have pen devices, programmed pumps, and jet injections. I've got a nice picture to show you. The first one is the Insulin Pen Injector, which is putting the drug in the form of a bolus below the skin. And the second one is Insulin Jet Injector, which is putting the drug in the form of pressure, and the drug is spreading. So both these are newer drug delivery system. So that's about the various routes of administration, the oral as well as the PAR-ENTERAL. Next we need to know, because I use this sentence sometimes, first pass metabolism. I said it number of times. So let's understand what is it. It's also called first pass effect. It is the metabolism or degradation of a drug that takes place even before the drug reaches the systemic circulation. And this is why it is called first pass metabolism. When the drug is passing through all the areas in which you have enzymes for degradation, like stomach, intestine, and also liver, if the drug gets broken down even before it has gone into the systemic circulation, started producing action, then you call it first pass metabolism. This is going to eliminate some amount of drug from going to the systemic circulation. And actually, if you give a drug by oral route, it is going to be highest right from you start ingesting the drug, right from the esophagus, stomach, and intestine is going to meet various substances which is going to start to break down the drug. So that's first pass metabolism, destruction by gastric hydrochloric acid, by the enzymes in the intestinal wall, and then in the liver when the drug reaches first through the portal circulation. Please understand, the drug is going to the stomach, intestine, getting absorbed in the systemic circulation, then going to the liver is different. This is something else. The drug is still in the intestine. Before going to the liver, there's another circulation called portal circulation through which it is going to go to the liver. And if a large amount goes to the liver, it's going to be broken down. So that's called first pass hepatic metabolism, because it happens in the liver. Because it happens before reaching systemic circulation, it's also called pre-systemic. Pre is before. Pre-systemic metabolism, before reaching the systemic circulation. and is going to affect the bioavailability. If the metabolism of a drug, pre-systemic metabolism of a drug is too much, you cannot give the drug by oral route of administration. We have a list here: isoprenalin, lidocaine, hydrocortisone, testosterone cannot be given by oral route because there is too much of high first pass metabolism. Whereas there are some other drugs who have got high first pass metabolism, but still you can give a little higher dose and you can manage. So you have a second list is used orally but needed in higher dosage. And a very classical example is propranolol. Please don't forget, they might ask you sometimes from all the beta blockers which one has got high first pass metabolism, or omit propranolol and rest of them will have comparatively low first pass metabolism. Then you have verapamil, nitroglycerin, pethidine and number of drugs. Next we come to the word which I asked you to pronounce, bioavailability. What is bioavailability? Let's understand what is dose. Dose is the amount of drug given to the patient. I am giving you 500 milligram tablets, so that's the dose. But how much is available to you actually inside the living being is called bioavailability. The amount of drug actually available to the patient for action is called bioavailability. The name which is used, the alphabet which is used to indicate bioavailability is F, and a simple formula can do it, that is the amount absorbed divided by the amount administered. And I put F here. So F is going to indicate the bioavailability. How much is absorbed out of what is administered. Suppose if I administer 100 is absorbed, then I say bioavailability is 100%. When you say 100%, it's 1. Please remember this. Highest is by intravenous route of administration, 100%. Sublingual is almost 100%. And it will be obviously less for the reasons which we saw of first pass metabolism by oral route of administration. It's going to be least by oral route of administration. And if you give a drug by oral route of administration by repeated dosing, look at this. Look at this. This is the response of the first dose. Then the second one. Actually, the response of the second dose should be same as the response of the first dose. But what has happened is, before the effect of the first drug is over, I am giving the second dose. So some drug from the first dose is remaining, plus I am adding from the second dose, then I am adding from the third one, so the response goes on increasing. The fourth dose, then the fifth, then the sixth. And if you want to look at the concentration, this is the way in which you get the concentration. You see a straight line. This is going to show the steady state concentration, or it can be seen in this way in another curve: first response, second response, third response, and again the straight line appearing. So this was regarding the first pass metabolism as well as the bioavailability.